A very good morning to all of you. This is Dr. Ashutosh from Tendapam Hospital, Lucknow. I am a vascular endovascular surgeon. Today we'll be showing a procedure video of endovenous laser ablation. No disclosures. First and foremost, indications. C3 to C6 disease, we have to do it. C2 patients, choose very wisely. All veins need not be ablated. Confirm the cause of symptoms, rule out other diseases. Do no harm. That is the most important. You might do more harm with the surgery than not doing it. Now our patient is a 60-year-old male with SFJ and SPJ incompetence who has a non-healing ulcer, as we will show in the picture. The first thing is we keep the table ready. You can see a puncture needle, guide wire, stab knife, sheath, syringe, laser probe, sclero if needed is prepared ready, and laser machine can be seen in the backdrop. So the first step is doing a nice screening of the veins. Here I am screening the below knee great saphenous vein. Why we want to screen? We want to see the continuity of the vein and again confirm the diagnosis. There is no recent thrombophlebitis, and this step particularly helps where to cannulate. So we want to cannulate in a straight segment of the vein which is going up till the saphenofemoral junction so that we don't struggle while probing. So this one step saves a lot of time. Can see the GSV within the sheath here. I am going up till the junction. We are seeing the junction, identifying the junction here. And this is a large lymph node mainly because of the large ulcer this patient has. He must have developed this lymph node. So the junction is also seen here. This step is a must before cannulation. Confirm the continuity of the vein. Otherwise, you might struggle with wrong puncture points. Sometimes the vein ends up in varicosities. The assistant is sprinkling saline. That helps as a nice interface for doing the ultrasound. And we have identified the junction. Now we are doing the puncture, USG guided puncture. We try to do it near or just in the above knee GSV. We don't want to ablate below the knee. So we puncture using a 16 gauge cannula, or you can use a micropuncture set as well. So here we have identified and we are introducing a wire. And now this one step helps in knowing how the probe is going to go. So if your wire is going nicely, your probe is certainly going to go. Stab knife, introduction of a sheath. So preferably use a 5 French sheath. Smaller sheaths can be used. Sheath has been put. We take the wire out because now we know it's in continuity and our probe is going to pass. We connect the wire to the machine. We already have preset settings, so we are selecting varicose veins medium to large in this patient. Most of the new machines have prefix settings. Now introducing the probe, again keep the ultrasound here. You can see on the ultrasound screen the probe is passing, and we can check because here the confirmation is important that you don't go in the deep vein. So never trust the light on the machine. One, you are giving unnecessary laser exposure. Second, the position will always be misguiding. You might be in the deep vein and you can see the light there in the groin. So you can see we have identified ourselves quite away from the junction. We sometimes even measure it. And now this step is very important. What we are doing is putting the patients in a legs up position. Compresses the vein. So we want the probe to be contact in with the vein wall only. Then we are giving tumescent here, again ultrasound guided because we have to be perivenular. We are using a pressure bag, IV set and needle. The tumescent we use is 500 ml NS, 2% lignocaine 25 ml, epinephrine and soda bicarb, 10 milliequivalent soda bicarb and 1 ml epinephrine. We go in the saphenous sheath and nicely infiltrate around the vein. Now this step is really the most important in the success of ablation and the post-op recovery. A good tumescence means a good laser procedure. So if you ask me, the key to good laser procedure is a good tumescence. If you don't give good tumescence, patient will have those bruising spots. If you don't get good tumescence, the vein will not collapse. You might have very early recurrences, or you will have segments of vein which are non-ablated. So now you can see a nice tumescence around the vein, and you can see in the center, the probe is just surrounded by the vein. There is literally nothing in between. And the key is with ultrasound you identify the sheath. Now these are the benefits of the thing we put in tumescence, epinephrine and bicarbonate. They increase the efficiency. Again, we are identifying the tip of the probe that we are not in the deep veins. Selected energy settings. The paddle is being used and laser is being withdrawn. So I am giving 80 joules per centimeter. You can see the ablation going on the screen. Again, you confirm by ultrasound that the ablation is just in the superficial vein. So my one hand is on the ultrasound and I am seeing on the screen. Here we will show you ablation very nicely. This again confirms that your procedure is being done nicely. So a good ultrasound during the procedure is a key to prevent recurrences and have a good procedure. So here you can see the ablation is going on very nicely. We continue the same process, withdrawals 1 centimeter, and we give the desired pulse of energy. Now wearing eyewear is important because laser does cause cataract, so do wear it. It is usually available with all the laser kits. And so we are withdrawing, and now once we have finished, we are checking. You can see nicely ablated vein. Now the next step is very important. I am compressing the deep vein and I am checking that we have not caused any kind of damage to the deep vein. This one small step of 1 second just keeps you at peace. Checking the adequacy of ablation, the vein is ablated nicely. Now we come to the other system. This is the short saphenous system. Can you see the large dilated short saphenous vein? And you can easily do it in this supine position with bending a leg little bit. We are screening the short saphenous vein. We had already done it in the pre-op. We know that we have to do ablation of the short saphenous vein as well. Identifying the saphenofemoral junction, again in the same way as we did the saphenofemoral junction. So this is the saphenopopliteal junction. There was significant reflux at this junction, and usually in patient with large ulcers we have to do this. Again, puncture in the same steps. You can see our needle going in and putting a wire. So the sheath we have not taken out. We will take out after this ablation because it usually requires some compression. We wanted to finish the procedure. So checking whether the wire has gone into the SPJ, saphenopopliteal junction. So we are good with the wire. Our probe will pass. So we can put a sheath here. So now we have a 5 French sheath. That's why we preserved it for this, because here we didn't want a larger sheath. 5 French sheath has been introduced. In the same steps, take out the wire, same laser probe, getting past. And again here the checking is very important because there's a very high chance you can go in the deep veins. So keep one hand on the probe, check if you're not going in the junctions. So you really don't need to be near the junction. You need to ablate the SSV. Stay 2 to 3 centimeters away from the junction. So here we are making sure again and again, coming back and forth, that we are not in the junction. And best is this view where you are confirmed seeing the probe in this orientation that you are far away from the junction. So we are withdrawing the probe adequately so that we are not at all near the junction. We really don't want the patient to have a heat-induced thrombus or a thrombus in the popliteal vein. And again giving tumescent. Before that we are locking the probe here also, taking extra precaution. And again giving tumescent in the same steps. So sometimes the SSV won't be in a sheath, so you have to give it in the skin above, but make sure the tumescent is adequate. Especially in these patients, it is of paramount importance. We are ablating 2 systems, and you see the vein is going down, it's collapsing on the probe. So we take some time in giving tumescence so that the vein collapses nicely. We can see a sheath here. We'll try to puncture the sheath and give tumescent, and this really helps. If you have a sheath around the vein, the tumescent distributes very evenly and collapses the vein. Again starting the laser procedure. Same way, here we are not giving too much of energy. We'll be giving 60 to 70 joules. And this is how we ablate the SSV. So we are checking the ablation, carefully ablating the short saphenous vein. And after this procedure, in some other cases where there are significant varicosities which are in communication, we can give additional sclerotherapy. This is from another case where you can see we are making sclero, 2 ml sclero, 3 ml water, saline and 5 ml of air. Tessari technique, always use lower lock syringes so that there is no leak. And then aspirate the sheath, make sure that blood is returning. And you can introduce sclero again, doing an ultrasound at this stage. Make sure that you are not extravasating the sclero and it's going into the right veins, and gives you the knowledge about the adequacy of the sclerotherapy. So this is practiced by some people for the below knee grade saphenous vein. because we can't do laser in the below knee vein due to risk of nerve injury. Post-operatively, we give immediate compression, can discharge the same day or day after depending on the logistics. Patient has to ambulate. There is no role of bed rest after varicose vein surgery. NSAIDs can be given for discomfort. Antibiotics if there are signs of infection or in cases with ulcers. Now, anticoagulations has to be given if and only if indicated. Now, what are the indications for anticoagulation? That we'll see in the next slide. Anticoagulation has to be given in only high-risk patients, like patients with strong family history of venous thromboembolism, non-thrombophilia, reduced mobility. So those patients can benefit from anticoagulation. Patients at low risk don't need any anticoagulation prophylaxis for varicose vein surgery. Follow-up, we do a Dopplex in the OPD at 1 week. We review the patient at 1 week and 4 to 6 weeks. Patient is told to resume strenuous activity after 2 weeks. Compression, so there are various guidelines. Most of them say 1 week of compression is adequate. But in C6 disease, in patients with ulcer, it has to be a prolonged compression with multiple phases, intense and maintenance. Thank you.